Thank you, Peter. So I am a research scientist, and while my office is here at Pennington, my research laboratory is not here at Pennington. My research laboratory is in schools, in preschools, in doctor's offices, and YMCAs. So our research is going out to where the kids are and where the families are. So I have the opportunity to spend just a few minutes introducing to you implementation science, and I hope it sets the stage for Dr. Cook, as well as the rest of our speakers throughout the day, who are all touching on this topic. Let me share with you just two quotes that really give meaning behind what I do, and perhaps what many of you do as well. The first is from now a young woman named Maria, who has worked with us for a number of years as a patient advocate. And she shared with us at 12 years old, I was told by my doctor that I would not live to see my 18th birthday because of my weight. My mom and I did not know how to implement this well-meaning advice we received into our daily lives. The doctor's office staff were nice and well-meaning, but it was not enough to support the behavior change I needed. So this is coming from the patient, from the child. And then I'd also like to share with you a quote from a pediatrician. This is actually from Dr. Sarah Hampel at Children's Mercy, who many of us know. And she said a number of years ago when we had a conference on child obesity, she said, "We feel and know that our children and families need better care. We need to push the field." And I'm happy to share with you now that Dr. Hampel and others are leading the charge for new clinical practice guidelines to treat childhood obesity in the primary care setting, which will be released just a few weeks from now. So this is where I'm coming from. This is my passion. But I'm going to take a step back and share with you a little bit about implementation science. So how do scientists bring solutions, evidence-based solutions, to the community in a way that community members and organizations can use the science and deliver it straight to families and children? So one thing that's really compelling that was written about 20 years ago, and this really helped to launch the field of implementation science, which is a relatively new field. It takes 17 years to turn 14% of original research into patient care. So just stop and think about that. These solutions, these programs that are being developed in the research lab and being published in scientific papers, on average, it's taking almost 2 decades to get those programs to the patients and the families who need them. And of that, only 14% are making its way to the bedside or to the community. So clearly there's a real issue here. There's a real gap between science and the community. Let me give you 2 examples that you may be familiar with, and the first is penicillin. And so penicillin was first discovered by Ian Fleming in 1928, and this was, I think we could all agree, a miracle antibiotic. But it took World War II until penicillin was starting to become widely available to the general public, and it's because those soldiers on the battlefield needed penicillin to stay alive. And so it took a war to really drive the will and the access to get penicillin available to all of us. Another example is smallpox. Smallpox has been around for hundreds of years, and in the late 1600s in particular, there was an epidemic in Boston and other cities around the country. And back then there was controversy over inoculation. But about 100 years later, a vaccine came out, and this was arguably the first vaccine to be made publicly available for an infectious disease back in 1796. 200 years later, the World Health Organization rallied together and said, we have the tool to stop smallpox once and for all. And so they had a goal to eradicate it by 1976. And in 1980, smallpox was declared eliminated, the first time that as a world we were able to eradicate an infectious disease. But look at that trajectory and look how long it took to get that, and think of all the lives that were impacted in the meantime. So what is implementation science? It's trying to bridge what we know and what we do. It's trying to bridge that gap. And a scientific definition of implementation science, it's a systematic and scientific approach to answer the questions about how we get what works to the people who need it for as long as they need it, and with greater speed, fidelity, quality, and relevant coverage, payment for the programs. And so it's closing this gap between what we know and what we do. And part of it is figuring out what are the barriers to getting these programs out to the community. What I'll touch on and what others will touch on specifically is child obesity treatment, because that's the theme of today's conference. But you could think about this as a pill for any type of disease, a policy, another type of a program. In implementation science, it's really not about evaluating so much the program itself, because oftentimes by the time you're delivering this program or this pill or this policy into the healthcare system, it's already been vetted by a lot of research trials, randomized controlled trials, systematic reviews. And so now it's becoming evaluating the implementation of it, of how do we get that program that's based on evidence, scientific evidence, and how do we get it out to the people who need it. So when I say evidence-based strategy, again, this could involve a variety of different approaches, strategies, and one of the ways in my field is the program of obesity treatment. What does that mean? That means an intensive lifestyle and behavioral counseling program, having families meet regularly with a dietitian, engaging in physical activity. Dr. Anelli talked about those systems influences, so helping families to influence the systems and trying to create a healthier environment for children. In obesity treatment, it could also include medications. It could include surgery. So that's kind of my focus, but again, this could relate to a variety of fields. So evidence-based strategies are what is being implemented. Implementation strategies are how we implement those into healthcare systems or into schools to deliver to the end users. So when you think of an implementation strategy, first of all, if you have a program that has evidence that it works, how do you get adoption? How do you convince or work with the pediatrician or the school teacher to actually use that program in the classroom or in their the pediatrician's office? How do you implement it? And then ultimately, how do you sustain it? Because if it's a program that requires financial support, organizational buy-in, if we bring programs that are tied to grant dollars that are not permanent grant dollars, we have to think about how to sustain it once those grant dollars go away or once the research staff go away. So it's really trying to think about how do you become pragmatic and deploy programs in a way that they're going to exist long after the project is over, long after the grant funding is over. I wanted to share a couple more quotes, and I think this will particularly resonate with the scientists in the room, but even for those of you who may not come from a scientific background, you may relate to this as well. To him who devotes his life to science, nothing can give more happiness than increasing the number of discoveries, but his cup of joy is full when the results of his studies immediately find practical applications. And coming here to speak to you today is a really joyful and delightful day because it's a chance for us to share some of our science with you and to foster these conversations and learn from you as well about what the needs are. And then one other quote to share is, the ability of science to deliver on its promise of practical and timely solutions to the world's problems does not depend solely on research accomplishments. So for us, that would be papers published in scientific journals and data, but on the receptivity of society to the implications of scientific discoveries. So there's the push of scientists trying to get the evidence-based programs into the community, but there needs to be that pull from the community too. So what does the community need? What do the families need? What are they interested in? And we have to kind of come to a good compromise where we're still following the science and following the evidence, but being really mindful of where are these programs going to go and how are they going to be implemented and sustained. So why do we need implementation science? We need to accelerate the uptake of these programs. If we have identified programs and pills and policies that work, we need to figure out how to get them out into the community. And we also need to combat misinformation, because if there's a void there, a 17-year void before the science gets into the community, what else is going on? What are those patients and families being told? And oftentimes, I think well-meaning, well-intentioned people try to fill the gaps. But unfortunately, oftentimes, things become watered down or ineffective programs get put into place, or programs that have not been tested and not been shown to be effective. And that's where we're trying to work together between the scientists and the practitioners to combat that misinformation. And there's actually a whole field called de-implementation science, and that's identifying the programs and the approaches that don't work and trying to remove them because they're sucking up time and money and resources, and we want to fill those options with the evidence-based approaches that are effective. There are many theories and models and frameworks about implementation science, and the three kind of overarching principles of how we go about this science is to describe the process of translating research into practice. So this could be everything from working with stakeholders from the very beginning, whether that's the school teacher, the PE teacher, the pediatrician, to make sure we know what is the end user, how is this going to be deployed in the school or in the clinical setting. Understanding what influences implementation outcomes. Just because we're sitting in a room today coming up with all these ideas does not mean when you actually go to the school or the community that program's going to be deployed like you think it's going to be deployed. So figuring out what adaptations are needed for the specific population that you're reaching, for the culture that you're working in, for the municipality that you're working in, and then ultimately evaluating the implementation. So this is a continuous process. It's not that you can just deliver a program or deliver a curriculum and expect it to run for years and years. It needs to be continuously monitored to make sure, are we still achieving the effects that we intended to? Do we need to adapt? And how can we keep supporting those practitioners that are the ones that are disseminating or giving the program out to the end users? So the key scientific questions that we go back to again and again in implementation science: what are the most effective techniques to improve distributing the evidence and the people who are receiving the evidence? If new evidence comes out, what's the best way to get that out to the end users, get that out to the organizations? And then importantly, and Dr. Anelli touched on this as well, what are the contextual factors that influence the implementation of those programs? And one very important example is this graphic that you've likely seen before, the difference between equality and equity. Right? So understanding what are the different needs and what are the unique needs of our children based on their household income, food insecurity, racism, access to health care, access to healthy food, and how do we make sure our programs are adapting and serving those youth? And that might look slightly different from the youth who don't have food insecurity, whose parents do have stable and high-paying jobs. So thinking through, how do we make sure we're giving equitable access to these programs? Because if you don't think about that, then you may actually increase the health disparity if you're giving programs that can only really be used and effective among a certain segment of the population. This is a selection, and I understand this text is kind of small, but I wanted to just walk you through a few different strategies that we use in implementation science to evaluate what we're doing. First of all, evaluation and iterative process. These are not scientists and researchers that are just staying within their own bubble. These scientists become the practitioners as well. And what I mean by that is, again, whether you're talking about a school-based program where you bring the teacher and you bring the parent and you bring the school principal in early in the process, or if you're talking about a clinical treatment where you work with the pediatricians and the hospital administrators early in the process. So you're always thinking about what's the end goal? How are we going to package this and distribute in a way that it's going to meet the needs of the organization, of the clients, of the patients, and the students? Adapting and tailoring to the context. We know here in Louisiana, we have different opportunities and challenges compared to Mississippi, compared to Colorado, compared to New York. And so really understanding the local culture and the context is quite important. Engaging the consumers, engaging the kids themselves and the parents to make sure the programs that we're deploying will really resonate for them. Because ultimately, if you build it, will they come? Right? So really understanding how can we deploy these programs in a way that they will be used. And then ultimately changing the infrastructure. Because when we're thinking about things like having a dietitian meet with a family regularly for several months to try to help the child and the parent to lose weight, to eat a healthier diet, that's something that's really foreign to a lot of our pediatricians' offices, a lot of our community health centers, a lot of our schools. And so if this is what the evidence indicates is what it takes, this kind of intensive counseling, dietary counseling, It's not just about planting that dietitian in that healthcare system or in that school. It's about figuring out how can we do so in a way that's sustainable so that that dietitian becomes part of the community, or if there's an existing nutritionist, that person can be trained and supported to deliver these types of programs. So really understanding the contextual factors and what are the things that we can do to make it easier to sustain these programs. And on this slide, I was just noting the variety of data that inform our approaches. Everything from EMR data, like what Dr. Anelli mentioned, market analysis. Some of these are, you really having to think about commercial markets and who are the people that are going to either purchase or use these programs at the end of the day. And I'm gonna skip ahead just a couple of slides so we can get back on track with the timeline. And I wanted to make sure I had a few minutes at the end to give you some examples of implementation science and practice as it relates to childhood obesity. And so for those of you who work with CACFP and in early childhood education centers, you may be familiar with the CDC's spectrum wheel of opportunities. And I think Renee Mixon this afternoon in her talk will touch a bit on this as well. But the whole idea is that when we're working, for example, with early childhood, with preschools, there's a lot of evidence to indicate that the current state of preschools has a lot of improvement for nutrition, for the foods and the snacks and the beverages that are being offered to children. There's a lot of evidence that, supporting breastfeeding for moms who have the opportunity to continue to breastfeed in those early months. Supporting physical activity, both indoor and outdoor physical activity, and reducing or eliminating screen time, that these are all really important healthy practices for early childhood education centers to adopt. So there's a lot of evidence to support that, but we know that preschool owners and teachers and administrators, it's a tough industry to be in. And they're dealing with staff turnover, and they're dealing with budgets, and there's a lot of standards for safety and hygiene, et cetera, that have to be met. And so sometimes when you go to a childcare center and you're asking them, oh, by the way, let's also talk about the snacks that are being served and the physical activity going on in the classroom, it feels like it's a lot. It's a lot to handle and to try to manage. And so what the CDC has done is indicate all of these different levers that can be pulled to integrate health into what is already going on. So whether that's the state licensing criteria, whether that's the quality rating system, professional development, both pre-service as the teachers are learning to become teachers, and then professional development offerings. So the things that already exist, how do we then create kind of health in all policies, health in all training? And so I think this is a wonderful example of implementation science of how we're trying to use the community partnerships and use the pre-existing infrastructure to try to incorporate nutrition and physical activity into what it takes to run a good quality childcare center. And then on the K-12 front, an example of this is the WISC, the whole school, whole community, whole child, from the CDC. So many of you are probably familiar with this, and the idea is to serve our children to make sure they have a healthy education academically, cognitively, social, emotional, and physically. We need to bring together our health departments and our education departments and our community organizations, that this is a holistic and comprehensive way to educate children to make sure school is a safe and healthy place for them to go to. And so I wanted to point you to this Rooney article in particular, that's kind of a guideline for how you can be an implementation scientist at your school or in your sector where you work. So how to plan and get the buy-in from administrators. If you identify there's a need, that there's a way to help improve health education or physical activity offerings or the vending machine snacks that are on campus, that there are step-by-step ways that we can each become an implementation scientist and look at the evidence, look at what's going on in the school, do some assessments, and then work together, bring together stakeholders and identify what are the priorities, what are the strategies, and let's come up with a reasonable timeline to try to chip away at some of these things to improve the school environment. So this is another illustration of implementation science at work. And then finally, my last couple of minutes, I'll speak specifically to the medical or clinical treatment of childhood obesity. I'll go through these quickly because you're going to hear a lot more from Dr. Cook and Dr. Queen on these topics later today. But I did want to point to and kind of set the stage for These are the U.S. Preventive Services Task Force guidelines, and they're actually in the midst of being updated right now. These are based on scientific evidence, about 35 years now, of what works in terms of treating childhood obesity. And you can see here that the recommendation is that clinicians screen all children for obesity and then offer or refer children to comprehensive multidisciplinary obesity treatment. So what does that mean? If you can read down here, the bulk of the evidence indicates that that family, that child and parent, spend at least 26 contact hours with a coach or a counselor, a dietitian, over the course of a year, working individually with that family to see how can we change that child's environment at home, at school, elsewhere, to encourage healthy food choices and physical activity. And so I won't go through all of these, but there's also a lot of really important psychological and behavioral change skills that are taught. How to self-monitor what you're eating in your physical activity, how to set realistic behavior change goals. And so we already have the guidelines and the guideposts for how to do this, but then the question becomes, why isn't this being done and offered in the clinical settings when we have so much of the evidence to indicate that this is effective, that this can help children lose weight or slow down their weight gain? And oh, by the way, it also helps the parents to lose weight as well. So we have all this evidence, and what will it take to get this implemented into primary care? So I won't steal too much of Dr. Cook's thunder, but he and I and some others are part of the Team Up National Child Obesity Study. And this is getting into the primary care setting, working hand in hand with pediatricians and dietitians to provide this kind of comprehensive obesity treatment to make this more accessible to children and families throughout Louisiana, as well as in New York and Missouri, and we're adding states with other projects as well. Here's just a quick map of where this particular project is located, but we're also working to spread this throughout the state of Louisiana. So I'd love to hear from you afterwards if you're interested in partnering up with us. And I wanted to indicate, yes, we are certainly looking at effectiveness of these programs. So, the weight of the child, the weight of the parent, and some of the other important health and psychological markers. But look, we're also looking at who is participating in this trial, what practices are signing up, and what practices are not signing up, which clinical practices are not signing up. We're looking at the adoption in terms of, is the electronic health record changing? Is the actual makeup of the clinician's office changing? And we're looking at implementation and sustainability as well. So this is implementation science. It is, yes, making sure our programs are effective, but making sure they're going to be taken up and provided more access, equitable access to as many families and children as possible. And so I will skip ahead a couple more and end with the Grow Healthy initiative. This is a very exciting new program that Pennington has just launched through a state investment. And the goal is to get our scientific solutions to the community throughout Louisiana. And so you can see here that we are supporting from the time a parent first discovers that they are pregnant to help the mother and the father or the partner to make sure that the mother's gaining an appropriate amount of weight during pregnancy, that mother has some good infant feeding practices for the child, is supporting to breastfeed, et cetera, but all the way through preschool and K-12 to support our schools with programs that will help improve health education, that will help support our teachers, but also these weight management programs in clinical settings to make sure our doctors and our dietitians are supported so they do have the tools and the resources they need to deliver these programs. And ultimately for adolescents and young adults to make sure there are pathways to medication and to surgery for those adolescents who have obesity and comorbidities and that need more aggressive treatments to help them to lose weight in a healthy way. So we are very excited about that program. We're also working alongside Dr. Denise Holston, who will also speak this afternoon, through some CDC funding. We will be working with a number of parishes in the next year to do some formative needs assessment to see if they are interested in a family healthy weight management program and how would that be deployed. And so be on the lookout for that. And in closing, I just wanted to revisit these two quotes and show that this is how we're trying to bridge that gap, that push from the patients themselves for better treatment options, and that recognition from the providers that we need to implement better options. So these are some resources I encourage you to check out from some of the professional societies: Dietetics, Psychological Association, Pediatrics Association, and the Preventive Services Task Force guidelines. And be on the lookout here, because there are going to be some exciting new guidelines coming out in the next few months. And that is it. So thank you so much for your attention.